Our first speaker is Paula Papanek, and she is an exercise physiologist whose research has focused on the benefit of progressive individualized exercise and lifestyle interventions on physiologic function and quality of life in populations living with cancer or other chronic diseases, with an emphasis on preventing osteoporosis and bone loss with aging and disease. These studies will significantly contribute to the understanding of program attributes and mechanisms by which exercise impacts the lives of African American men and women living with prostate cancer and breast cancer, as well as prevention of bone loss with healthy lifestyle interventions. Our second speaker will be Dr. Mona Al-Mukaddam, who's an associate professor in the Department of Medicine and Orthopedic Surgery. She is director of the Penn Bone Center for the Division of Endocrinology. She received her medical degree from the American University of Beirut in Lebanon and a master's degree in translational research from University of Pennsylvania, where she has completed her endocrinology fellowship. She is the co-investigator on NIH grants utilizing novel MRI-based techniques to evaluate structural and mechanical competence of bone and to monitor osteoporosis treatment effects. She is the world-renowned expert in fibrodysplasia ossificans progressiva and is a principal investigator on industry-sponsored clinical trials in that disease. Thank you.
Well, thank you all for hanging with us and being last woman standing, I guess. I'm from Chicago, so we talk fast, say things like you guys and you want to go with. So lots to say, lots to do, and I'll go as fast as I can. My disclosures are really none. I'm not supported by any industry. I'm supported by the NIH, and so that's good. And again, there was a doctor that's following me, so if you want to ask specific questions regarding medical care, well, then that's why we have a doc following up. I'm a physiologist, exercise physiologist, a physical therapist, and an athletic trainer. More letters after my name than in it, which was a goal. All right, so, obviously we're talking about the metabolic bone disease, so osteoporosis. And most of us think about osteoporosis in the context of old ladies, all right? And really what osteoporosis is fragile bones that fracture when they shouldn't. I'm not talking about if you get hit by a Budweiser truck and you get broken. All right, that's logical. All right, I'm talking about sitting and you turn and you fracture, rolling over in bed, sitting up against gravity, fractures that are abnormal for the conditions. 10 million Americans have osteoporosis, and that's probably a gross understatement. 44 million people are at risk due to low bone mass, all right, and this is probably the tip of the iceberg because we don't really measure this until people are 65. All right, and I always say that that's the horse is already out of the barn by then. But what do we know? 1 in 2 women and 1 in 4 men will fracture, right? Around the age of greater than the age of 50. A woman's risk of fracture is equal to their combined risk of breast, uterine, and ovarian cancer. All right, we need a really good ribbon, all right, for osteoporosis that people pay attention to this. It's not on your radar, all right? It's on your radar because of your risks, all right? But it's not on most people's radar. A woman's chance of fracture across her lifetime is pretty darn high, right? And so what I'm basically saying is that, you know what, you're women and yes, you have other risk factors, but you still are women. And you still get all the other risks and all the other disease that women get, including osteoporosis. So that means you got to pay attention. Again, I'm not saying it to scare you. I'm just saying it because this is important, even if you have cancer or other risk factors. So why are we discussing this at force? All right. Well, obviously there's a connection between cancer and bone, or we wouldn't be here. All right. Breast cancer is common, 1 in 8 women. Prostate cancer, 1 in 8, and the risks increase with age, just like osteoporosis. Right. 1 in 2 women fracture, 1 in 4 men. Those risks go up with age. So we have these crossover of risks culminating so that if you're breast cancer and or prostate cancer, then your risks are even greater than the average population. So overlapping risk profiles, and it's happening right now. All right, just an example of this, all right? This is an NIH study that I was involved in, community dwelling women, age 40 to 60. In order to be in the study, you couldn't have osteoporosis or know about it, all right? Know that you have osteoporosis. So they were young, healthy, capable of exercising, and had a BMI of greater than 29, a nice chunky Midwest population, right? So they wouldn't be on anybody's radar for being osteoporosis. But when we did their baseline measures, this is just the baseline data, not why we were enrolling them, we had 3% who had osteoporosis. All right, another 6% who had very low bone mineral density, that my endocrinologist likes that term, all right, and another 30% with low bone mass. So what does that mean? Okay, we can't see that from here. There you go. All right, we had 40% of our women who had low bone mass and 10% who were already in trouble, right? And they wouldn't be on anybody's radar. We literally sent 9 women to be evaluated, all right, that are in a young group, and the majority response was, what do you want us to do about it? Okay? That's a sad response, right? And the point is that at this BMI, they weren't on anybody's radar. Healthy, active women, capable of participating in exercise. The only reason they knew what their bone mineral density was because we measured it. So why is this happening, all right? So let's think about this. Name another disease that we don't treat until after you have it, until after something bad happens. Right? If your cholesterol's high, your blood pressure's high, do we wait for you to have a heart attack? No. Okay? So why do we wait for you to fracture or till you're over the age of 65 before we begin to think about this? Right? And so in order to really prevent this, you need to know and understand a little bit about your bone physiology. That's why I'm here. Right? How we measure that, how physical activity can prevent this, how do you prevent falls, and really begin to think about your individual risks. Medicine should be individualized, right? And it should be actively you participating in that so that you know what your risks are. So let's get rock and rolling with this. What do bones do? What's calcium? Why do we care? Right? Obviously, it's the structural component that keeps us up against gravity. Right? That's good. Right? And we come into this world with a nice floppy skeleton. And anybody who's had a child should be saying, thank you. All right? Because if your skeleton was mineralized as an infant when it came out, that would really be awful. All right? And obviously it protects our organs. All right? We have this nice rib cage and bone that all protects our organs, you know, and does a nice structural protection. That's good too. Locomotion. Without our bones, our muscles wouldn't have anything to pull on. You wouldn't be able to ambulate. You'd just be a little amoeba of muscle. But what most people don't realize is that it's our savings deposit overdraft protection for calcium, right? All right, plays a critical role in calcium homeostasis or in calcium balance, all right? Other minerals are stored there too, but the one we're talking about is calcium. And so why is calcium important, all right? Why do we care about calcium? Calcium functions in every single cell of the human body, 100 trillion of them, right? It does things like bone and teeth, all right? Our muscle and cardiac and smooth muscle all require calcium in order to function. Nervous system, the fact that you're sitting here thinking and going, well, she's kind of crazy, talks fast, okay? That activity alone has you using more calcium, right, than if you were just sitting here passively. Blood clotting, all require normal calcium. So as you're sitting here, and as we're thinking, or I'm talking, or doing more activity, I'm using calcium, right? And we have to have calcium not only to survive, but to thrive and to optimally function. Constantly using calcium and draining our plasma pool. Now, there wasn't any calcium in our snack break, okay? All right? There wasn't really any except for that one little slice of cheese on the beef sandwich at lunch. So unless you're walking around taking calcium tablets, you've been doing things all day long, your plasma calcium levels are low. How many of you could feel that? Oh, yeah, low calcium. I need to do something about that. No, can't use it, can't feel it, and you don't know how much you got right now. So who's taking care of this? Your bone, all right? It's your bone's job to take care of your calcium. So again, if your plasma calciums are a little low right now because you didn't have a sneaky snack of yogurt in between here, your plasma calcium drops, all right? It signals specialized cells, there you go, Specialized cells in your bone, osteoclasts, and I always remember this, clasts chew, kind of like a little Pac-Man game, goes in there, chews up the bone, all right, the active ends of your bone, and what does it do? It's called bone resorption, and it spits out calcium. Spits it right out into your blood, brings your plasma levels back up, and our cells in the body are happy. Yay! All right? And as our calcium levels go up, the signal turns off, all right, and says our calcium levels are normal, stop doing this. If, in contrast, you're walking around with yogurt, all right, and you had 2 yogurts in this break, your plasma calcium levels have gone up, and instead that signal has gone to osteoblast, blast build, says osteoblast, build that calcium. Put that calcium back in your bone reservoir, save it for later. All right, I'm gonna need it, really, okay? Save it, all right? And so that's called bone formation. Pretty easy, right? And so this is a balance that's happened constantly as you're sitting here, all right? And how many of you could go, oh, my bone, it's a little weak right now. I must be taking calcium out. Oh, no, calcium's going in. Again, all right? You don't know, all right? This is stealth. This is happening without you aware, without you pretty much ever thinking about it, and really never saying, hey, I need to do more, I need to do less, I need to think more, I need to think less, I need to do more activity, less GI. It's happening very beautifully. It's wonderful physiology. I could spend days just talking about this. Obviously I won't, right? But bone's dynamic, happening minute to minute, second to second, all right? When we bone resorption, all right, depending upon what we've eaten, all right, or bone building, filling up these little pits right over here, happening dynamically, constantly, all right, without your awareness, opposing signals. And whether your bone are strong or weak right now depends on who's winning, okay? Who's winning this? Today, this week, this month, this year, this decade. That's what determines your bone. Osteoblasts build, osteoclasts chew and spit out the calcium, all right? And this matrix of calcium and phosphate is what makes our bones nice, solid, rigid, and structurally stable, all right? The changes are imperceptible. The good doctor's gonna come up and talk about how we're measuring some cool things and some really high-tech technology to look at this, but basically you can't feel it. She can measure it, but only with some really cool equipment. All right, so this balance determines what your total bone mineral density is. Again, stealth, can't see it, can't feel it, all right, only with really cool equipment can you tell. So you don't know if your bone matrix is nice and solid or it's wispy and crumbly like a Jenga set, ready to crumble. All right, so let's look at some bone across your lifespan, all right? This is age across the x-axis, your bone mass, all right, in grams of calcium going up there on the y. All right, look at this bone growth. Good thing we come out with that floppy skeleton. As we age, and particularly hit through puberty, our testosterone or estrogen goes in, and we start laying down bone. We are at our maximum growth velocity. Our bones are getting big, thick, and strong. All right, and so right here is what you want to optimize. So go back. All right, y'all go back. All right, and now that I know this, make sure you get lots of good exercise and eat your calcium, your vitamin D, and get some sun, protein, and take care of your bones. All right, so not a great message to give to 14 and 15-year-old girls who are worried about weight. And when you're worried about your weight, what's one of the first food groups you drop out of your diet? Dairy, all right, high-fat dairy, right? So mixed messages all the time, right? So we got to pay attention to this, right? Then we hit our peak. Tell my students, 20s and 40s, it's peak. You're 24 years old, it's downhill from there. Pretty much all physiology. It's downhill from 24. All right, but we hit our peak. All right? And then we hit this. Wow, that's quite the slope. All right? And you all know this slope to be menopause. Okay? Now, notice when I had this age, I had this in the 50-year-olds. All right? Pay attention to this, because if you're going through menopause for a different reason at a different time, you're on a different time frame. Same physiology, different time frame. And then we hit this other slope, all right, that we're going through, but we're still losing. We're still losing bone, unless we do something to keep it. So here was your genetic peak. If I could turn this on. Here's your genetic peak, all right? All right, here's my bone growth. I really wanted to optimize this, but I didn't even know this. Holy Christmas, nothing I can do about it. All right, I got this loss that you may not have had any control over, and now you're out here. All right? And you want to keep your bone mass as high as you possibly can so you don't have a fragile fracture just sitting there. Men, all right, what's the difference between us and them? They have testosterone, so their bones are generally bigger. All right, they don't have menopause. All right, they have male pause. All right, but they have it in their 70s, much later time. All right, and so their peak is higher, and they don't typically reach their fracture threshold until much later in their 70s, unless they do what? Have their testosterone suppressed through something like ADT. So, okay, understanding about bone, just like this little bit, it's going to help you understand how to maximize and sustain what you have. All right, gain what we gained all what we're supposed to gain our max in our 20s. Well, that's too late. I don't know any 20-year-olds who want to hear me talk about their preventing diseases in their 60s, menopause, or any change in their reproductive cycle for any reason. Bone doesn't care. Bone does not care. You either got the stuff to sustain your bone or you don't. Men hold on to it longer, and we can't go back in time. So all we can do right now is talk about optimization. All right, so what do we do? All right, well, let's look at bone physiology. Here's your bone, okay? All right, the little arrows are things we can't do much about, all right, including your genetics. Not much you can do now about who you chose for your mom and dad, okay? You can ask how their bones are, right? And it gives you a little bit of a window as to what your future might be, but ultimately you can't change that, all right? Let's think about age. Can't do much about that, okay? Gender, our genetics gender, we can't do much about that. Some medications you don't have any control over, right? And so then we have the things in the green arrow: nutrition, exercise, hormones, drugs, alcohol, and smoking. Right? Now most of these things you're going to be thinking, this is a positive influence on my bone. If I have nutrition, it's going to impact my bones. It will if you have it. What if you have bad nutrition? Then it becomes a negative factor. Physical activity, we'll talk a little bit more about that. If you have it, it's good. It's a U-shaped curve though. If you have too much, you can also develop fractures. And if you don't have enough, you don't provide a signal for your bones to grow. Same thing with hormones. Hormones are great, until they're taken away. Then not so great, right? And so while we generally think of these as being all positive factors, it depends on whether you have them or not. So how does physical activity work? Kind of a complicated slide, but not really, all right? Basically what this says is that your bone shape and size are influenced by the direction and magnitude of forces. So if we all stood up here and just did this, up on our toes, I went boom, on my heel. I slammed ground reaction forces through my tibia, through my femur, into my hips and into my pelvis and right into my lumbar spine. Okay? Nice forces coming right up that chain. I have a compression force pushing on that bone. And what does it do? It causes a little bit of bend in order to absorb the force. And that force stimulates those osteo B's for blast to build, right? And I begin to build a little bit of the osteoblastic matrix around here, and then it mineralizes the end of the bone. That's really it. That's forces of bone, physical activity on exercise, and exercise on bone. And that's, all right, and that helps bones reshape themselves to be ready in case you do something that's crazy like this again. All right? That's literally how physiology works. It tries to adapt in anticipation of what you're going to do next. Okay? So applying forces to a bone is a good thing. And for us as humans, the forces we're talking about is physical activity. I'm sorry, I'm trying to block me out here. All right? There's a name for this. In physiology, it's called Wolff's Law. All right? Wolff's Law basically says that osteoblastic activity is directly proportional to the forces we put on a bone. All right? So if you do this a lot, you get more plastic building. If you sit all day, you have very few forces on the bones, you have less osteoblastic activity. All right? And as we age, all right, the balance of those forces naturally go toward the direction of chewing and not building. And so we have to fight aging and sedentary lifestyle and those optimization of forces so that we can maximize our bone. The forces include pulling at the tendon, that's a force, compression forces, gravity, and exercises against load, right? This all day long. And so exercise and physical activity positively influences bone, and that explains why active women have higher bone than sedentary women. And if you were going to think about this, all right, you're thinking about different activities, who do you think, name a sport, that you think would have really strong bones?
Soccer players.
Soccer, they run. And what else do they do? Jump like crazy. All right? What about another women's sport?
CrossFit.
CrossFit, okay? They do a lot of lifting and workload, and they do some of this jumping type of stuff. Volleyball, big jumping, jumping, runners, okay? Coming up to the Olympics, name one. They're little teeny tiny humans. Gymnasts, okay? All right? Gymnasts, jumps, goes through the air and lands with 12 times their body weight. Not the only weight 10 pounds, but still 12 times their body weight when they land. Okay? So is there any reason you can look at a spectrum of women athletes and say, sedentary, okay? What about swimmers? Where do they fit? Yeah. Strong, but in zero gravity. They're in water. So they get a little bit of activity because their muscles pulling on their forces. Then you get runners and jumpers and gymnasts, oh my, all the way up to really strong bones. And that's exactly right. And it makes perfect sense based on Wolff's law. Okay? You men are weak athletes. All right? Women who have a normal menstrual cycle have higher bone mineral density than sedentary controls. Everything else is matched. Okay? Except their athletic activity. Explains the benefits for physical activity across all ages. There's no doubt physical activity is great for bones. So does it work? Okay, I'm not expecting you to read this. It's in your handouts. All right, I just picked 3 slides. I just picked 3 studies. 60 to 70-year-old women, 75-year-old frail women, okay, 60 to 70-year-old women. What they do, okay, progressive exercise, resistance training, then endurance. Started with easy flexibility, balance, and range of motion, walking, then vigorous. Right? What do these all have in common? Progressive overload exercise that's variable. Okay? Right? Body doesn't want to do the exact same thing. It wants to. Yes, ma'am.
What does progressive overload mean?
Progressive means, all right, that I started with this load. I'm good at this. Now I progress it to the next load. All right? So it's always getting a little bit harder. If you're exercising and doing the same thing every single week, what kind of results can you expect? What I got. What I had. Okay, am I going to get any bigger? Better? No. Body's in the same stable plane. You got to challenge the body with a progression each time, getting a little bit harder, not every single day, but variable, all right, and a little bit harder all the time. That's what the body doesn't like, because it's like, oh, that was crazy, girl. Why'd you do that? All right, I better get ready in case you do it again. All right, now I'm ready. Got to do something more. All right? So progression. So what they had in common was that they progressed, all right, the load, and they varied it. Okay? They did some resistance training, they did some jogging or stairs, they did intensive walking, they did all this, and what did they see? In everywhere that they measured, a bone increased. It doesn't matter. 30, 40, 50 studies. We're all going to say the same thing. The variations on how much they gained that had to do with pre or postmenopausal. How old the women were. Okay? What was their hormonal status? Did they have kids? Okay? On and on and on. That's what changes how much they gain. But in general, a proper exercise program will increase your bone mineral density. All right? So how can we use this? All right? Well, bone needs loading. All right? So you might like to swim, you might like to do water aerobics, but you're not doing that for your bone. Doing that for your heart, doing that to make you happy, okay? But not for your bones. Right? You need to change the load. Progressive. You need to continually progress it and provide variability. Surprise! Okay? For everything. Your heart, your muscle, your bone likes to be surprised, not constant. High load with low repetitions. I'm going to jump 5 times. Okay? All right? Low load with high repetitions. Walking for a longer time. Okay? Speed of load, rate. How fast are you loading those bones? Okay? What direction are you loading those bones? All right? Am I just doing in one plane? Am I doing in different directions? Okay? Bone likes to be challenged. That's how our body works. Not surprising again, who's got the highest bone mineral density for their mass? Gymnasts. Okay, look at this. Those inhumane, incomprehensible activities, flying through space, landing, and we only get to see the good ones, right? I mean, they've been doing this for decades, right, in order to get here. So think of the loads that their bones have experienced over time, right? Right? And you need to do this whether you are at risk for cancer or not, because you're still a human. You still have bones, okay? And you don't want your cancer corrected and to die from a fracture of osteoporosis. That's preventable. Osteoporosis is a preventable disease. It's not normal consequence of aging. So, mini summary. Low bone mass is caused by losing bone to the breaks. Okay? Low bone mass is caused by losing what you have until they get fragile. Right? Bone mineral density declines as the number of menses, menstrual periods, accumulates for any reason. Bone is agnostic. It doesn't know why you don't have estrogen or a menstrual cycle. It just knows you don't. Okay? It doesn't know if you're a guy why your testosterone levels are low. It just knows it's low. Okay? For any reason. Stress fractures are more common in women who have abnormal menstrual cycle than those who don't, given the same training program. We've known this since the 70s now. Okay? Severe undernutrition for any reason, low energy, low calcium, low protein, impairs your reproductive cycle, that impairs your hormones, that impairs your bone. Okay? So what are we talking about? A nice holistic view of, good nutrition, a proper load, making sure that your bone environment is optimal so you can hold on to what your parents gave you. Okay? Bone and muscle do best when we provide them with variable changes in activity and we surprise them. All right? And remember, we can't feel this, we can't sense this. It's like atherosclerosis or blood pressure. Unless you're measuring it, you don't know. It's silent, imperceptible, and I like to call it stealth physiology. So if I can't feel my bone mineral density, what do? Well, you'll hear about some really cool measurements later, all right? But you can do some other things. This is a DEXA, all right? Your bone strength and your risk of a fracture is directly proportional to your bone mineral density, right? All right? And we can measure this in a DEXA. It's passive. It's one of the best medical tests in the universe. You go and you lay it on a table for about 2.5 minutes, take a nap, go to your happy place, work on your grocery list, and they'll tell you, and then your bone mineral density comes out. Whoop. Right? In this case, her knees are bent, so I know that they're doing a lumbar spine. Right? If her legs were out, rotated externally, and in a funny position with a spacer between them, I know that they'd be doing her hips. Collectively, total body, lean, lumbar spine, and hips all come to your nice picture. Right? What we're worried about, we're not worried about a fracture of your brain. Right? We're worried about a fracture of your spine and of your hips. So that's why you want to have those measured whenever you have this test done. So a DEXA is a very low dose radiation exposure, something that is much less than a mammogram, okay, or an X-ray, or a CT of anything that you can do. It's less, in fact, than flying from here, where am I, Philly, than flying from here to California, all right, in terms of radiation exposure. It's less than dental X-rays. So if it's so low dose radiation, and it's so easy to have this done, how many people are having this done every single year? Every year. Well, okay, we have 1.5 maybe. Okay, 2, I'll go with 2. 2, do I have 3? 3, give me 3. 3, I have 3.5. Okay, do I have 4? 3, 3.5, I can't, I'll give you 3.5. Okay, in the room. All right? So what does that mean? It's not being done enough. Not being done enough. How many of you have your lipids, cholesterol measured? How many of you go to have your blood pressure measured in the doctor's office? How many of them in the doctor's office ask you how much physical activity you've gotten in terms of weight bearing? Okay? Right? Where's the disconnect? Every physician in the universe knows this. I know because I teach them. All right? In basic medical school. So they know this information. It's just not translating, all right? And so the DEXA is the gold standard because it's easy, right, to do. Yes, we have much better methods, all right, that are a little bit more invasive. It measures your bone mineral density. It correlates with your fracture risk, okay? Typically done, and most important to have your lumbar spine and your hips done, all right? And it's covered by Medicare at age 65. When did you lose your bone? In your 40s and 50s, right? Okay? Yeah, you should all be outraged. Okay? All right? If we had more women in Congress, we might get this changed. All right? So we need to write to all the congressmen's wives, all right, to get them to change this. All right? Many cancer programs now do include a DEXA. So if you've had a DEXA, amen. Good for you. All right? At least you've had one. All right? Why one? Okay? What does a single point in time tell us? Imagine Google Maps. All right? You are here. Where have you been? Well, I don't know. Where are you going? I don't know. But we know you are here. Okay? It tells you where you are today. All right? Doesn't tell you anything about your trajectory. You need 2 points to create a line. That's simple math. You'll learn that. Now, see, kids are learning this now in kindergarten. 2 points make up a line. So if you are here, you're going, uh-oh, I'm in the osteopenia range, and I am, let's just say I'm 58. I had an early test for menopause. Am I happy? Well, maybe. Okay? If I was here 10 years ago, and I'm holding on to my bone, what am I thinking? Thank you, I'm doing great. But if I was up here, if I was there, or if I was, that's not bad, okay? But if I was up here, 10 years ago, I'm thinking, help me, okay? I'm losing bone way too fast. And the only reason I would know that is because I have 2 points. So if you have 1 point, great, go get a second point. And ideally, get it done by the same DEXA at the same institution. So, bone mineral density is dynamic, affected by your lifestyle, affected by who you chose for your parents, all right? It's affected by, particularly by your physical activity and your nutrition and your hormones. We understand bone physiology. You're going to hear my colleague talk up and say, we absolutely know and understand that osteoporosis is pathophysiology, all right? Can't feel it, all right? You have to have us to tell you, measure it. Okay? But a DEXA is cheap, and a lot of universities do it. All right? Look for a clinical trial or research study that's doing it and get it done for free. Okay? It's grossly underutilized. It's pathophysiology, not an inevitable consequence of aging. And shouldn't our goal be, as care providers and as humans, okay, to prevent the first fracture? Osteoporosis is defined by most people as a fracture. A fragile fracture. Now we'll treat you. Why do we wait for the first fracture? We don't wait for your first heart attack. That's silly. Right? Okay? We have to change this. Primary prevention is what you're interested in today. All right? The identification of people with diseases and medications are something that my colleague will speak about a little bit more. All right? And again, cancer definitely relates to your bone health, all right? And the way that it really relates is inflammation. This is key. Cancer is an inflammatory disease. Anybody with chronic inflammation, I have RA and has significant, inflammation, all right? Inflammation causes cardiovascular disease, causes osteoporosis, causes a lot of different things, but it definitely chews up your bones. Cancer is an inflammatory disease. Cancer is an inflammatory disease. Don't forget that. All right? And so lots of medications, all right, also are risk factors, all right? Medications for inflammatory diseases are also risk factors. And so now you have to think about talking with somebody who's an enlightened physician to talk about your bone health, to put this all in perspective, to again have an individualized plan for you, not one size fits all. Bone loss and cancer, reproductive cancers, is not a secret. We have known this for a long time. Here's normal menopause. Premenopausal women losing about 0.5%. Early menopause, 2% per year. You can lose 8% of your bone mass or 10% going through menopause at any time. All right? Here's androgen deprivation. Here's ovarian failure or chemotherapy. Look at the percent of bone loss per year. This is not a surprise, but it seems to be a secret. Because we're not telling anyone, except those of us that have the information. Okay? Now you get it. Okay? So, again, cancer mechanisms and medications in particular will come up, so I'm not going to go over this a whole lot because I don't want to steal people's thunder. All right? Breast cancer, prostate cancer treatments impact bone. The treatments impact bone, the cancer impacts bone. Getting a DEXA done is easy to do. 2 points give you a line. All right? It's cost effective. All right? Allows us to do a whole lot of stuff, plan to live a long time, even with your cancer. Don't have osteoporosis because you survived cancer. Okay? Feed your bones. Calcium, vitamin D is important, as is a good quality protein. All right? These are standard guidelines for calcium and vitamin D. All right? There's nothing magical about this. All right? And y'all get these slides. Don't worry. All right? Y'all get these slides. All right? So let's think very quickly. Let's wrap this up. Cancer and exercise. There's lots of benefits to doing exercise for cancer patients and people at risk for cancer besides your bone. All right? It modulates pain, decreases anxiety and depression. It's empowering. All right? It decreases cancer fatigue and brain fog, decreases cardiotoxicity, and blah, 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 blah. So what is exercise bad for? Why wouldn't physical activity be part of your prescription? Who should you see? A physical therapist that's cancer certified or an exercise physiologist that's cancer certified? And besides cancer, physical activity is really good for you because you're still a human. You still get cardiovascular disease. You still get diabetes. You still get atrophy. You still have sarcopenia. You still have all these other types of things, okay, that we know exercise is good for. So again, be proactive and protect and keep your bones strong because they might not be on anyone else's radar. All right? It's a lifestyle, not a race. Even with HR 2+, ER+, PR+, that's particularly sensitive to physical activity, to decreasing cancer reoccurrences. So there's a lot of reason to be doing exercise. How can we help? How can I help? All right? A couple of things. Be patient with yourself. It's a lifestyle, not a race. I'm not asking anybody to become an Olympic gymnast. You probably missed that window anyhow, okay? But I'm not asking you to become an Olympic marathoner, all right, USA Triathlon, Senior Olympics, none of that, okay? Asking you to find what you like and what you enjoy, okay? If you have sharp or shooting pain, stop. That's not a normal response to exercise. Track your pain. How do you feel today? How's your pain today? How's it tomorrow? More than a 2+, you went out a little too hard. Okay? Decrease your effort by 50% and start again. It's okay. Forgive yourself. Okay? The best exercise to do is the one you'll do. And it's going to be different for everybody in this room. All right? So, in summary, physical activity, load-bearing, dietary calcium intake, quit smoking if you do. Decrease your alcohol intake to moderate amounts if you do. All right? See an certified exercise physiologist or a PT with expertise in cancer. They are there, and you can go out to web pages and find them. You know about your bones. We're going to hear more about meds. Feed your bones. Physical activity is vital. You don't have to be these folks in order to reap the benefits of exercise in your life. Perfect example. 2 NIH-funded studies. One in prostate cancer, lifestyle intervention. Midwest, okay? We'll put these on board. But if you're in the Midwest, Milwaukee, Chicago area, physical activity to break the cycle of cancer and cancer fatigue, cancer and lifestyle. Metastatic, one of the few studies in metastatic breast cancer. Most people avoid working with metastatic disease. All right? Again, every day counts. An individualized, meet one-on-one with a certified exercise specialist to work with you. You can't come in today because you're wiped. That's okay. We'll see you next week. Individualized exercise program, right, is what you can do. If I can do nothing else than for you today to empower you to say, I gotta do something, do something. Good luck.
All right. Can you hear me? All right. I'm Mukaddam, and I'll be talking to you guys about how to treat your low bone mineral density. I can promise you to talk as fast, but I won't be as funny. All right, so disclosures, I do receive industry-sponsored funding, but that's for fibrodysplasia osteogenesis progressiva, nothing related to this talk. So we heard about osteoporosis, we heard about low bone mineral density, and we heard as well that it is a silent disease. And so how can we screen for that? How can we detect it early, and when should we start treatment early? This is what I'm going to be talking about, and I'm also going to be talking about what are the medications that we use, so more pharmacological therapy that we will be using, and what are the things that I think about in terms of your other health issues and what other medications you are on that would make me think like maybe this is not a good treatment option for you. So I'm going to go through the first set of my slides very quickly. They're almost like a repetition of what's already been done so nicely. But I do think that, when you think about osteoporosis, right, so basically what it means is the bone is porous, right, so there's holes in the bone. And the clinical definition of that is that it's a bone that is low in density, so you don't have a lot of bone, and the quality of it is not good, and that predisposes you to having more fractures. So this is an image of a vertebra, which is normal, so you can see it's dense, and the trabeculi and the bone are very well connected. This vertebra is someone who doesn't have a lot of bone, so it's transparent, but also there's loss of connectivity, and so this hole will make this structure much weaker than this structure and more likely to break. Extremely common in the general population, and there's several things that can increase your risk of having osteoporosis. I mean, Paula highlighted it so nicely, and I think I'm going to bring her with me to clinic and get my patients to be big osteoporosis medications because she does it so beautifully. But I think looking at the different risk factors, we thought about the things that are modifiable and things that are not modifiable. And the things that, there's a lot of medications that can negatively affect your bone, and there's a lot of health conditions that can negatively affect your bone. And I think when we're thinking about, cancer treatment, a lot of our patients are, or preventing cancer, they're on, estrogen suppression medications or testosterone suppression medications. A lot of people are having heartburn or reflux or taking high doses of acid suppression medications like proton pump inhibitors. And there's certain cancers, like as you mentioned, the inflammation part of it, the cancer, and there's certain cancers like multiple myeloma that on its own increases risk of fractures. So why is it important to screen it? We talked about osteoporosis being a silent disease. You don't have symptoms, so you do want to do some form of screening to detect it early, to treat early before someone breaks a bone. I'm not going to be talking about all the fancy ways we can evaluate bone quality. I think it still remains true that DEXA scan is kind of the gold standard. It's cheap, it's readily available, most centers have it. It has a lot of limitations because you're measuring the bone density as a two-dimensional structure, but we know that bone is a three-dimensional structure. We know that bone is made out of different compartments, and the DEXA scan cannot differentiate those different compartments. But you know what? It's there, it's very cheap, and we have a lot of normative databases, meaning that there's been a lot of DEXA that's happened that we've done on a lot of people, so we kind of know what the average bone mineral density should be in different age groups. And that's helpful, because then that allows us to use these standardized terms that you guys will hear, T-score and a Z-score. So just kind of going over what are those two definitions. So the first one, the Z-score, is basically the number of steps or the number of standard deviations your bone density is away from the average bone mineral density of someone of similar age. So I'm comparing your bone density to someone of your colleagues, your cohort of people the same age. And that we use to define if someone's bone density is below what is expected for their age. And we use a z-score of -2 or below to say if someone's below what is expected for their age. This is basically just a statistical technique, right? So if you were to get 1,000 patients and measure their bone mineral density, you always have a normal distribution, right? Not everyone's going to be right smack in the middle. God did not create us all the same height, right? We have shorter and taller people. And so you can see that with including a z-score of -2 to +2, you're going to have 95% of this population is going to be in here. At the tail end of this, which would be 2.5%, this could still be normal, but it's just too low for us to be comfortable with that. So we use a z-score to say if you're below what is expected for your age. The t-score is when we're comparing your bone density to the average bone mineral density of a young cohort. So now we're comparing your bone density to this peak bone density that we were talking about. So if you look at this figure, the t-score is always comparing to this peak bone density, which is this line. And the z-score is comparing to what we would have expected for someone your age. And the reason we use a t-score and not a z-score to define osteoporosis is because we don't want to undertreat our older patients. So if I have a group of 80-year-old patients, and they do their bone density, and their bone density is hey, we're all good, we're -1, -1.2, high five, our bone densities are similar to each other. Well, we're missing a huge group of them that might break their bones. And so in order to better risk stratify our aging patients, the t-score is much better at doing that. And so the t-score is really intended for postmenopausal women and men above the age of 50. And the numbers that we use is a t-score of -2.5 or below. So the more negative it is, the worse it is. We define that as being osteoporosis. A t-score between -1 and -2.5 is low bone mineral density. And thank you for not using the term osteopenia, but that is one of the terms that is used, osteopenia. And the normal t-score is that of -1 or above. So how do we diagnose osteoporosis? So one way of doing that is by DEXA scan, so if the t-score is -2.5 or below. The second one, which we want to try to prevent, but if someone already has a fragility fracture, so if someone, again, was turning around and had a compression fracture, I don't care what their DEXA tells me anymore, right? They're clinically telling me they have osteoporosis, so that trumps everything else. So any history of a low trauma or fragility fracture, a t-score of -2.5 or below, and then now, and I've really shifted my thinking as well, to including the definition of osteoporosis to people who are at high risk of having a fracture. So when you look at DEXA scan results in the general population, most of us are going to be in the osteopenia range, just because it's the most common. And so because most of the people are going to be in this osteopenia range, most of the osteoporotic fractures actually happen in people who have osteopenia and not osteoporosis. And so there's been studies to show that about 50% of patients, if you were to, who've already had an osteoporosis-related fracture and you were to do a DEXA, half of them would not have osteoporosis per DEXA scan. And so we're going to be really missing and undertreating people. And the reason for that is because when someone breaks a bone, it's not because of only their bone density, it's because of multiple factors. Age being one of them, rheumatoid arthritis being another, prednisone, smoking. So there's so many other risk factors for why someone would break a bone. And DEXA is only one of them. And so for that reason, we have different calculators to help us predict what is someone's risk of having a fracture in the coming 10 years. The one we use in the United States and most commonly used is called FRAX. And so we can plug in certain characteristics and calculate what is the risk of having a fracture in the coming 10 years. And if it's 20% or more for a major osteoporotic fracture, or more than 3% or more, or 3% or more for hip fracture, these two numbers are high enough that now we can call these patients as having osteoporosis, and meaning that we would recommend treatment as well. This is an example of FRAX. There's a newer one called FRAX Plus, but you have to pay money for it, so we're still going with the cheap one. But really looking at different factors that we look at and plugging them in there, And you can calculate this number with or without a DEXA scan. And it gives you two numbers, the risk of having a major osteoporotic fracture in the next 10 years, and then the risk of having a hip fracture in the coming 10 years. If you see here in the bottom, it says adjust with trabecular bone score, so that's TBS. That's a relatively newer software, but it is FDA approved and can be applied to the spinal images that are acquired during the DEXA scan. It's supposed to be a textural parameter. So you remember how I showed you the picture before of the spine where the bone was very well connected versus this one. So you can imagine you can have two structures that might have the same bone density, but if the bone density is more uniformly distributed, that structure is going to be stronger, versus you can have a structure with the same bone density, but there's a hole in the center. That one is more likely to break. So that's what the trabecular bone score is. It's a textural parameter to try to tell us more about the bone microarchitecture or the bone quality. Trabecular bone score is not intended to diagnose osteoporosis, so there's no T-score, Z-score numbers that we use right now. It's not used for monitoring of treatment because we don't know how it changes, and a lot of the treatments that we give, it doesn't really change. But we do use it to better risk stratify our patients. So we can plug it into their FRAX to recalculate the risk of having a fracture in the coming 10 years and determine if they're high risk or not. So again, in summary, osteoporosis is very common, even if you don't have any cancers. It affects both men and women. It's a silent disease, and so it's really important to do a DEXA scan before the fracture happens. In terms of treatment guidelines, I think what I tell we know this is amazing when she talked about it, this is something that's important for all of us, right? It's important for my kids, it's important for me now, and it's important for my mom. About adequate calcium intake. So we never encourage excessive calcium intake, we recommend adequate amount of calcium. We do try to encourage it more through dietary sources because of concerns with calcium supplementation, potentially increasing risk of kidney stones and maybe cardiovascular issues, but adequate calcium intake is important. It's usually around 1,000 to 1,200 milligrams of calcium. In someone who has GI issues, has had surgery, or is taking acid suppression medications, calcium citrate is better absorbed than calcium carbonate. So if you are on a calcium supplement, better take calcium citrate. Vitamin D, very controversial, but my recommendation is to aim for a 25-hydroxyvitamin D between 30 to 50 nanograms per ml. And then exercise and fall prevention, right? So we talk about osteoporosis, we talk about bone mineral density, but what I really care about is you not breaking a bone. That's really what I care about. And if you fall, and you have a bad fall, you might break a bone no matter what I do. And so fall prevention and exercise and early mobilization is extremely important, as well as trying to minimize anything that could negatively affect your bones, whether it's smoking, excessive alcohol, use the lowest amount of doses of prednisone that you need, and exercise. So who do we treat? So thinking about our general population, we treat our patients who have osteoporosis. So either osteoporosis defined by DEXA, or osteoporosis defined by a fragility fracture, or if they have a high calculated risk of a fracture by FRAX. Now, in people who have cancer, or people who are going to be starting medications that could potentially decrease their bone mineral density, we use different cutoffs. Different guidelines have different cutoffs for what numbers to use, but in general, if I know someone's going to be started on a medication that will decrease their bone mineral density, the cutoff is usually between -1.5 to -2, where I would start treatment earlier and not wait till they become osteoporotic. If when we're doing this follow-up DEXA scan, those 2 points, if they're having a significant decline in their bone mineral density, then I would want to start treatment early. And then also people who have this kind of moderate risk of having a fracture, maybe not waiting till it's more than 20%. Maybe I'll start treatment if it's between 10 to 20% instead of waiting till it's more than 20. All right, so what do we use? I'm not going to go over all the medications that we have for osteoporosis treatment, but I just wanted to highlight a couple of things. In order for a medication to be approved for osteoporosis treatment by the FDA right now, the requirement is that the studies demonstrate that they decrease risk of fractures. So fracture outcomes is very important for a drug to be approved. Compression fractures in the spine are the most common fractures. So you will see that all the medications that we have been shown to decrease risk of compression fractures in the spine. Hip fractures are less common, so not all the medications have been shown to decrease risk of hip fracture. The other thing about osteoporosis treatment, so as Paula was mentioning about what's happening, right? You have the osteoclast and you have the osteoblasts, right? So what's happening, no matter what the underlying physiology is, what's happening is there's an imbalance between the amount of bone being removed compared to the amount of bone being formed. So you have more osteoclast activity compared to the osteoblast activity. So as you can imagine, when we're trying to treat osteoporosis, we're going to have a medication that will either decrease the amount of bone being removed, so these are the osteoclast inhibitors, or we can have medications that stimulate bone formation, so these are the osteoblast formation and bone formation, what we call osteoanabolic agents. So the ones that decrease bone loss are going to be bisphosphonates, so that's what was thought of as gold standard or first-line therapy for osteoporosis. So that would be like Fosamax, Actonel, Believa, and the infusions are V-class or zoledronic acid. They have been shown to decrease risk of hip fractures by about 40%, and compression fractures by about 50 to 70% over 3 years. The pills like Fosamax can cause a lot of GI irritation, so we don't give it to someone who has esophageal problems. Some of the people who have graft versus host disease might not be a good idea. The infusion of zoledronic acid can cause flu-like symptoms with the first dose. It could worsen renal dysfunction. And then I will talk separately about atypical femur fractures and osteonecrosis of the jaw. These are two side effects that have resulted in severe undertreatment of osteoporosis, to be honest. And then we have denosumab, which is Prolia, and it's given 60 milligrams every 6 months. And also that's been shown to decrease risk of hip fractures as well as compression fractures in the spine. In terms of side effects, it can increase risk of infections, it can drop the calcium level. Atypical femur fractures and the osteonecrosis of the jaw that I'll be talking about soon has also been shown to occur with denosumab. And another thing that I will spend time on is the rebound bone loss that can happen with this medication, denosumab. Estrogen is effective, but of course, from our concern about breast cancer is something that we do worry about. There are estrogen-like medications that I'm not going to talk about, but like tamoxifen or raloxifene, that could be protective against breast cancer that has some positive effects on bone. So they are protective in that sense. And then talking about medications that stimulate bone formation, so we have 3. One is teriparatide or Forteo, which is given as an injection daily, subcutaneously for 2 years. And abaloparatide, which is Stimulus, which is also given as a subcutaneous injection for 2 years. And then the newest one, which was been around now for 5 years, is called Evenity or romosozumab. Teriparatide and abaloparatide work on the parathyroid hormone receptor. And in rats, it was shown to increase risk of bone cancer or osteosarcoma. So it's one that we don't recommend if someone has skeletal radiation or someone who is actively undergoing cancer treatment. And so that's not one that would be it's not going to be studied in breast cancer or prostate cancer patients. And so this is not one that we routinely use in our cancer patients. Romosozumab, it's the newest medication that we have. It's the strongest one because it works by both decreasing the amount of bone being removed while stimulating bone formation. There is a boxed warning about this medication regarding increased risk of heart attacks and strokes. More on that later, but again, not one that has been necessarily studied in cancer patients, but it is an option in our severe osteoporotic patients. So let's go over the osteoporosis medications that also have oncology indications. So bisphosphonates, so IP zoledronic acid, has also been approved for oncology reasons. So it's been approved for patients who have cancers that have metastasized to the bone. It can be used for patients who have high calcium because of their cancer. And it's used to protect the bones from the negative effects of the treatment that is given for cancer. And in multiple myeloma, it's given as part of the treatment of cancer. These medications, zoledronic acid as well as denosumab, they're osteoclast inhibitors, so they inhibit the osteoclast. And in that sense, they can also protect the bone from the cancer metastasizing to the bone. And there's also some data about IV zoledronic acid decreasing risk of breast cancer recurrence as well. So they have very favorable indications in cancer, not only in terms of decreasing risk of fractures, but also with cancer outcomes. The one thing to note is that the doses are different. So with osteoporosis, we give 5 milligrams once a year of zoledronic acid, versus for different cancer indication, it could be 4 milligrams every 3 to 4 weeks. Similarly with denosumab, what we give for osteoporosis treatment is 60 milligrams every 6 months. In cancer, it's called Xgeva, and it's 120 milligrams, so it's double the dose and then given more frequently. And why is that important? Well, because the side effects are going to be different, slightly different. So I will go over these 2 side effects that we mentioned. So one is the atypical femur fracture. This is a very weird fracture that happens. It's a stress fracture in the thigh bone, so it happens in the femoral shaft, and it can happen without any trauma. And it starts off with this, some cortical thickening, some changes here, and then that progresses to a complete fracture. The risk is very low, and this risk, we have definitely seen it in people who've been on bisphosphonates for over 5 years. So in the past, we used to think of osteoporosis like hypertension. You take a blood pressure medication, you stay on it for the rest of your life. And so that was initially what we were doing with osteoporosis. Someone starts Fosamax and they take it for the rest of their lives. And then, they started seeing these cases of people coming in with these really weird fractures while they're on Fosamax for 14 years, 15 years. And so now we've definitely shifted how we treat osteoporosis, where we recommend bisphosphonates for 3 to 5 years and then give the body a break or a drug holiday. But the atypical femur fracture that happens in doses that are given for osteoporosis treatment. The osteonecrosis of the jaw is different. The osteonecrosis of the jaw almost rarely ever happens when it's as part of osteoporosis treatment. So we usually tell our patients, you're more likely to be hit by lightning than to get osteonecrosis of the jaw. It's much more common in cancer because you're given much higher doses, much more frequently. In cancer patients, they're usually undergoing chemo, radiation, or prednisone, so they have other risk factors. So the risks are different. But what is osteonecrosis of the jaw? It's basically necrotic bone in the jawbone. This is a really severe case. It doesn't have to be like that bad. But it usually happens after invasive dental work, like dental implant or dental extraction, where the jawbone is exposed and it doesn't heal for over 8 weeks. There's different stages. This is one of the worst ones. And I'm not putting this to scare you guys, but I just wanted you to know that I am aware of these side effects when I'm prescribing these medications. And despite that, I will still prescribe these medications. The other thing that I wanted to go over is denosumab, which is something that we in the endocrine world or the osteoporosis world are very much aware of now, where we know that denosumab works very well while you're on this medication, but if the dose is skipped or missed, there's rebound bone loss that happens, very progressive, very fast bone loss, and that can be associated with multiple compression fractures in the spine. The problem is, in oncology world, when they're using denosumab, the studies are for 1 year to 2 years, and then no one knows what happens with these patients afterwards. But this can happen. So this is, I chose specifically a case report in a patient who had lung cancer with bone mets who was getting Xgeva, so 120 milligrams. And then they thought that he developed osteonecrosis of the jaw, and then they just abruptly stopped the denosumab. And then 9 months later, 9 months from the last dose of denosumab, you can see this is in figure B and D, the patient had multiple compression fractures. And you can see it in here as well, in all of the thoracic spine and the lumbar spine. And I've personally seen that as well, where oncology patients are getting denosumab, they think they don't need it anymore, they stop it, and then they come with multiple compression fractures. These poor patients end up getting multiple biopsies because everyone's convinced this is the cancer coming back in the bone. But it's really not. It's rebound from denosumab. So it is very important that we are all aware of this side effect, and so I keep mentioning it. So in summary, osteoporosis and fractures are common in the general population and are associated with significant morbidity and mortality. Certain cancers and their treatment can increase risk of osteoporosis and fractures. Denosumab and bisphosphonates are shown to decrease risk of fractures, but also can have some cancer benefits. We always need to monitor for short-term and long-term side effects of these medications, but always, the basics is, stay healthy, exercise. What's good for your overall health is going to be good for your bone health as well. So that's really essential for all of us. And with that, I thank you, and I guess you should give us some feedback, and yeah. Yes, questions, go ahead.
I'll pop up here really quickly. My first question is wondering if, I know you both said that the presentation was going to be available, but on the app, it's not available to download as a PDF for either of you. So I was just, I don't know.
That's strange, because I provided a beautiful PDF copy.
So I don't know if maybe our force advocate person could pass that on,
I
or.
would definitely pass that on.
If not, if you know my name, okay, I'm at Marquette University, so paula.papanek@marquette.edu. Email me.
I'm sure we consented to providing those slides, so you should be able to get
We can
them.
follow up.
For 3 days or something, they were telling me 3 or 2
Yeah, so,
And it could be because of someone like me that didn't provide their consent until like yesterday or 2 days ago.
Sure. Okay.
Along
Very-
with my slides, they email me, where are your slides, where are your slides, where are your slides?
I'm very sympathetic to that.
Yeah.
That's how I work also, unfortunately.
otherwise email me.
okay.
Email us. Who's
Great.
not going to answer you if you have questions? Seriously.
Thank you. And then my questions were, I saw that I have 2 questions, and the first is about excessive caffeine and excessive soda being kind of bad for bones and bone health. What is excessive considered for that?
Well, the problem is that they're both, that is a great question. So the problem is that from soda, it's a high phosphate. That's what gives a fizz. The phosphate binds to your calcium in your gut, and you pee it out. That's the problem. All right. Now, how much is too much? How much calcium are you eating? All right. How much are you getting it throughout the day, or did you drinking your calcium, taking your phosphate when you took your calcium, your Tums at the same time? So it's not an easy question. So
Okay.
I can't give you a specific answer. I can tell you that in teenagers who are dropping their dairy and increasing their diet soda content, we know that there's a risk for low bone mass.
So it's any carbonated beverage.
Any phosphate carbonated beverage.
Okay, so our
Spring
plain
water-
fizzy
spring water's
water.
Probably, if it's naturally carbonated water and it doesn't have phosphate in it, then you're good.
Okay.
So
Champagne's probably fine.
So I will tell you, I'm a LaCroix, fizzy person all the time, and I keep looking up the data. I suspect it's probably not going to be good for us, but there's no data specifically yet.
Exactly. Okay, you can't have 4. You can have 2
But
Diet
it's
Cokes,
really
but
the
not
Diet
3.
Coke. It's really the Diet Coke. They said the Coca-Cola and the Pepsi. So it's the dark,
And the acids.
the dark ones. Yeah,
Right.
those are the ones that have phosphates. So the sparkling waters that we're all drinking right now, we don't have any data yet that it negatively affects your bone. Probably it does, but we don't have any
Again, it
data
has
yet.
to do with the phosphate.
And is there milligrams of caffeine? Is there any guidance around the caffeine?
I mean,
No.
I think honestly it's going to be it's usually the caffeine in the coffee. So some of my patients like to do half decaf, half caffeinated.
Okay.
Definitely not more than 3 cups of coffee a day.
Okay,
So-
definitely not more than 3 cups of coffee a day. Okay.
I'm in trouble.
And then my other question was vitamin K. I've heard a lot over time about calcium and vitamin D, but then I keep hearing about vitamin K, but there wasn't any vitamin K on your slides. So what can you tell us about vitamin K?
Yeah, I don't want to tell you anything about it, because I don't think there's so much that is kind of, okay, or maybe, or not sure. Do you have a position, do you tell people vitamin K?
Yeah, no, so I actually got asked that question right before coming in here from another patient. And the response to vitamin K is biologically it makes sense, right? So in the mouse model, we know like vitamin K and its role with osteoblasts. There's been studies about vitamin K improving bone mineral density, maybe some data on fracture risk, but it has always been inconsistent. and no one knows what the dose is supposed to be for vitamin K to be helpful to actually decrease risk of fractures. So my approach to things and the way I try to highlight them is when I'm recommending pharmacological therapy, I'm really recommending it if there's data that it can decrease risk of fractures. And I don't think we have that with vitamin K. I think that vitamin K can be also available in green leafy vegetables, and so you can get it naturally.
That's right.
A lot of the calcium supplements that you see already in the on the market, like Biactive and calcium for bone health, they already have vitamin K in them. You can look it up. Almost all of them have some vitamin K in them. It's just we don't know how much is really needed. And then also with vitamin K, if someone's on Coumadin or warfarin, you worry about interference with like clotting factors and other things. So my job, at least, I try to recommend things that have evidence base that it can decrease risk of fractures. So I don't want to recommend it to my patients, but if they ask me about it, that's kind of the response that I provide.
I would agree.
Thank you.
Hi, I also have two questions. The first is, given what we know about the rebound risk from Prolia, what's the current thinking when you finish, the 5 or so years of treatment on what you should be doing to kind of lock in those benefits so you don't lose them?
This is, it's a
Challenge.
it's a huge challenge.
So
It's a huge challenge. So there's a, so the question was about what to do with the rebound bone loss that happens with denosumab and what to do next. So we don't just stop it. We give bisphosphonates afterwards. So we give either zoledronic acid or we give, Fosamax. If people cannot take either of those, we end up giving something like tamoxifen or raloxifene or something.
For how long?
There are guidelines that have been published that have been recently updated as well from the ECTS on how to discontinue patients from denosumab. And again, all of the studies that were done at looking at denosumab discontinuation, whatever we did, patients still lost bone density. So there was no way for us to completely prevent the bone density loss from happening. The general guidance is that if someone is young, try not to start denosumab because younger patients are more likely to lose bone density if you start them on denosumab versus if they're older. The longer you are on denosumab, the higher the risk of rebound bone loss. And so now we're saying, okay, maybe 2 to 2.5 years, and then those patients maybe can do well with oral bisphosphonates or IV zoledronic acid for 1 to 2 years. For people who've been on denosumab longer than 2.5 years or 4 years, 5 years, we are monitoring like bone markers and every 3 to 6 months and then redosing them. And they're still losing bone density, unfortunately. We're not able to prevent it, but we're hopefully able to prevent the compression fractures from happening.
Which is interesting given that they're doing clinical trials on denosumab as a cancer prevention in our population.
Yeah, I know. So denosumab, so this is the thing, I know. So I do give talks and it's an ongoing thing. So denosumab is an excellent drug. There's also data that, maybe it's more efficacious compared to IV zoledronic acid in multiple ways. It's just the problem is how to safely get people off of denosumab. I think that's really the biggest concern that we are facing. Obviously, not everyone will get a compression fracture in the spine, so it's less than 5% of people who will get compression fractures. But again, it's something to really think about. So again, at least in my osteoporotic patients who are going to be started on denosumab, I have a very long discussion about, are you going to be on this for the rest of your life? I have some patients who are like, you know what, you're going to be on it and you're going to stay on it. Like my dad is 81, he's on denosumab, and I told him, you're going to be on it for the rest of your life, and that's it. So I think having the discussion on how to safely get off of denosumab before starting it is important.
So my second question then is, everyone agrees that there should be drug holidays, or I guess in most cases following these medications. It seems like most of the guidance on that are assuming that you're starting this process at 60. For those of us who are starting it at 40, what does that look like? What does a drug holiday look like? At what point should we expect that we're going to be restarting at some point? Is it just DEXA scans? Like, how do you think about this over a 40-year period?
Yeah,
So if someone's been off of medications for 10 years, it's completely out of their system. So I would treat them almost like treatment naive, honestly.
Okay.
But yeah, so I think, once someone's been off of the drug for a while, we monitor their DEXAs, we monitor their bone markers. I think about your fracture risk and what other medications you are on. So again, it's individualized, it's very much personalized, and it's depending on your own risk. Have you ever broken any bones? If not, your bone density is stable, you're doing well, maybe I'm not going to restart treatment. You're off aromatase inhibitors, you haven't broken any bones, then I wouldn't treat you.
Thank you.
Yeah.
First, thank you so much for the wonderful lectures that you gave today. Really appreciate them, both of you.
Yeah.
So one quick question. Regarding exercise, a lot of people are using rebounders, like small trampolines. Is that a good exercise, or the shock of, is lessened with the rebounder?
What do y'all think? Okay, rebound. Okay, so you need to get some strength training with that and some great balance training. Gonna help you prevent a fall, and I love that because you may not, if you don't fall down, it's a whole lot less a fracture. But is it really going to provide the forces through your spine and your hips to give you the bone stimulation? Not the same way. But is that the exercise that you'll do as opposed to sitting? What's your favorite then? Well, then that's my favorite. That's my favorite exercise now. Okay? And so everything has to be done. Well, what exercise will you do? So the best exercise for you is the one that you'll do. Right? And if that makes you happy and it's challenging you and you're providing variations to that, and you're doing some single leg and some double leg and you're getting a dynamic, robust back, that's fantastic. But are you doing it to build bone in your spine? Then that's not my choice. That wouldn't be my first choice. Okay? But a great question. Nice question. Yeah.
I'll make it quick, I hope. Okay, I'm 49. I'm in surgical menopause about a year and a half after my Lynch diagnosis. And I did a DEXA scan just to get a baseline. And I know my doc doesn't like using the term osteopenia either, but I do have some. We also have a family history. My mom was petite like me, and so I know I already have that kind of against me. But I have been a runner on and off pretty much for the last, about 35 years since high school. I hope that has helped me to some degree. But because I was in surgical menopause, I kind of switched to more like, resistance and strength training and less into my running. Now I'm thinking, after hearing your presentation today, a little bit of both.
Resistance training is fabulous.
Okay.
Resistance training is fabulous.
Yeah, good.
And resistance training is fabulous because it provides a load. It's pulling on both ends of the bone when you're doing those type of things. And so resistance training is a very important component for exercise.
Good.
And so those studies, in fact, that I put up there from the meta-analysis, they were all resistance training exercises.
Yeah.
Okay? And we've done, the tough studies have done resistance training in octogenarians, people that are 80s, 90s, even centurions, 100 years of age, and showed maintenance of bone mineral density with resistance training.
Nice.
So don't
Awesome.
let go of bone of resistance training.
Awesome. The other thing is, my gynecologist had mentioned relaxophane. Am I saying that right? And you mentioned you weren't going to talk about it in this presentation. If there was any particular reason, or is it something that should be considered because of my risks, I guess you could say?
No, I think I should have added it.
Okay, gotcha. Because it came up in the last session, actually, in the menopause.
No,
session.
I think I should have included it. As I was going through my slides, like, why didn't I include it? Because it's very relevant. I think in young patients like yourself, and if your lowest bone density is in the spine, I think raloxifene would be a great idea, right? Because it's protective against breast cancer. It has data that it can decrease risk of compression fractures, but no data on the hip. So it's not a very strong one. It's not the best that we have, but I think in young people like yourself, your risk of having a hip fracture is not really what I worry about right now.
Yeah.
That will increase more when you're in your 60s, and so I think for now this would be a reasonable option. It could worsen your hot flashes.
Okay.
And increased risk of blood clots as well is something that can happen with raloxifene. So it's something to think about with raloxifene, but I don't think it's an unreasonable option.
Okay, good. Thanks for confirming.
Yeah.
I know we're at time, so I'll try to make this fast. It's kind of a two-parter, but so 49, Lynch syndrome as well. About 2 years ago, I had my colon completely removed. How does that impact absorption and my risk?
Absorption of
Calcium.
Calcium and,
Shouldn't be a matter. Just your colon, it shouldn't be a problem.
yeah.
okay.
If it's just your colon, it's not. It's usually in the gastric bypass patients or upper GI. It's going to be the upper GI. Colon, there's really not much absorption of calcium in the colon.
So the part two to that is because, so just yesterday, like latest test results came back for some imaging that I had to have. So 6 months ago, like the thoracic spine degeneration was just like age-related, nothing like out of the ordinary. Yesterday it says severe diffuse bone I can't talk right now.
Demineralization.
Thank you. Consistent with osteoporosis with the L1 vertebral body measuring less than 100 HU. So like 6 months ago, it was just like all age-related, and now it's like severe. And like, what is the HU? Like
So this was a CT scan, I'm assuming,
yeah,
hospital units.
yeah.
This was on a CT scan.
So is that why the HU is different than all the other?
HU, it's not a
Okay.
T-score. It has nothing to do with the T-score.
Right,
It's
right,
just
right.
like the hospital units. It's a CT-based technique. But I don't know how to interpret these results, to be very honest, on a CT scan. Usually when they do it on a CT scan to measure your bone mineral density, they would scan a phantom at the same time. And you can do that. I mean, there are techniques that can measure volumetric bone mineral density. But this is just a radiographic evidence of your bones are not mineralized. That's all that it's saying. I think you still need to follow it with a DEXA scan.
Sure.
I
That's-
think your
I made a
DEXA
note of
scan.
that.
Yeah, I think you just have to follow it up with a DEXA scan. And yeah, and the trabecular. So the thing is, it's probably because you have degenerative changes in your spine. Again, talking about DEXA, like it's what we use, but it has a lot of limitations. So if you have degenerative changes, aortic calcifications, anything like that, these are artifacts that would make the bone density look falsely better than it really is.
Okay.
And so your DEXA scan in the spine might be an overestimate of what your actual bone density is. So I think your doctor has to just to kind of look at all of these factors in terms of the imaging reporting that you have demineralization.
Okay.
And then taking your bone mineral density in the spine with a grain of salt because of all the arthritis that you have in your spine, that will not make it as reliable. Again, there's going to be a lot of factors that your doctor will have to look at. It's hard to respond.
No, thank you. I appreciate that.
Yeah.
And the one thing that I would add is I always tell my patients calcium and protein.
Yeah,
So
right.
you have to make sure that you're not protein deficient.
Right, yeah, no, and that's a big thing. I mean, I'm vegetarian, right, so obviously always seeking protein sources and things like that, so working with a dietitian and,
So you have to check with your dietitian and make sure that you're absorbing in your upper GI system that's still functioning all the components
Right.
of your proteins.
yeah.
As a vegetarian. Protein deficient, because that's a real problem.
Right, well, I mean, that kind of leads into another issue I'm having with my kidneys and like the protein not being broken down and the kidneys aren't using, like, I didn't even know the kidneys needed like protein and things like, I don't know. Anyway, so they've got me like having like a massive amounts of protein, Prostat and things like that to try and make sure that,
Right, if you don't have enough protein, you can wash out your concentration gradient in your,
yeah,
you can't concentrate your urine.
yeah, that's me. So, okay, thank you.
We'll be right on.